there's a Taiwanese saying that goes something like this. 你卖吞口放屁好不? Literally translated, it means that you are taking your pants off just to fart. What it's saying is that you are doing unnecessary work to accomplish a task. And that's exactly something that I saw today in clinic when I read an office visit note that came from a urology private practice clinic from the Pacific Northwest. I read a 13-point review of systems documentation included in this office visit note. I believe this was done unnecessarily for this patient with BPH and ED, and I suspect that it was documented by the urologist thinking that's what's needed for proper evaluation and management coding. I hate to break it to you, but after 24 plus years, those 1997 rules changed in 2021. That's right, 2021, almost 3 years ago. And one of the questions that is commonly asked by folks across the country as I'm presenting these talks on coding and billing is that, does this just apply to Medicare, or is this something that is required to be followed by all the payers? Well, this is actually a HIPAA requirement for all the payers to follow because these rules came down from the AMA. And of course, Medicare adopted it as well back in 2021. So evaluation and management codes, documentation requirements changed in 2021. Now, in general, for the office and other outpatient services, we are talking about evaluation and management services for the clinic in this video, okay? I'm going to talk about evaluation management services that you provide in the clinic, such as a private urology clinic. In general, there are two ways now since 2021 that you bill for an E&M visit. It's either based on time or medical decision-making. Time or medical decision-making. And time, in the past, you need to include 50% of the time involving counseling and coordination of care. So that was pre-2021. Post-2021, that is no longer the case. You get to count the time for the documentation, gathering your thoughts and documenting the encounter and discussing the case with other physicians, discussing the case with the patient and the caretakers. And that time, the entire time that is, and also, of course, the time for face-to-face with the patient, all that time is included when you are counting your E&M visit based on time. So that part has majorly changed. And you can look this up on the AMA's website. Look up evaluation and management. There's a nice write-up of the 2021 changes and all the interim addendums and updates. So based on time versus medical decision-making, time is pretty straightforward. And I limit my use of E&M billing based on time to typically prostate cancer and other cancer discussions. I usually schedule those via telemedicine at the end of the day or at the end of the morning so I can really just take my time and discuss things with the patient and family, typically. And as I'm doing this via telemedicine, usually a bunch of family members are in the visit, and also sometimes family members from different parts of the country in the visit while the patient is in Arizona where I'm licensed to practice. So there are some rules with telemedicine, synchronized audio and video visits. You definitely want to be mindful of should you decide to do telemedicine and practice urology. So there's time, all right? So once again, office visit evaluation management, time versus medical decision-making. Now, let's talk about medical decision-making, which is 99.9% of my office visits and E&M coding. It's all based on medical decision-making. It is much more efficient to document based on medical decision-making versus documenting based on time. For the same amount of time, I can generate a lot more RVUs when I'm documenting based on medical decision-making versus documenting based on time. So from a purely productive production RVU productivity, output perspective, documenting based on medical decision making is a lot more efficient. Now, let's talk about medical decision making. Within medical decision making, listen to this. History and physical examination are no longer needed for billing purposes. I'll repeat. History and physical examination are no longer needed for billing purposes. And you may be thinking, what? That's correct. Since 2021, you no longer need a physical, no longer need a history for billing purposes. Now, notice I'm very deliberate in what I'm saying here. For billing purposes, you clearly want to document clinically relevant, medically relevant history and physical examination when you're taking care of the patient, so that next time when you see the patient, you know what you're doing and what you plan to do. And also, when somebody else picks up that same note, he or she will be able to continue the care of that patient. In Arizona, that type of documentation, that level of documentation is needed to be compliant with the Arizona Medical Board. And I believe the state in which you're practicing, they will require that as well. So when it comes to billing, history and physical examination are optional. History means back in 1997-95, you need that 4 points in the history of present illness, and then multiple points in the past medical surgical history, 13 points in review of systems, multiple points on physical examination that you need to hit either for a new patient for sure, and then optional for an established patient. That is all gone. Okay, that is all gone. You do not need to do all that for billing purposes. You do want to document that for good medical care, right? So medically, clinically relevant documentation, history and physical examination, clinically relevant history and physical examination, you want to write that down. You want to document that. But for billing purposes, not needed. So then how do you document for medical decision-making when you're trying to figure out the coding level? In medical decision-making, there are 3 elements under consideration. And no matter what type of visit, 3 elements are under consideration for you to come up with a level. You need to satisfy 2 out of the 3 elements to reach a level. And the 3 elements are problem, data, and risk. Problem, data, and risk. So you can have a problem and a data for at level 3, you get a level 3 visit. You can have a problem and risk at a level 4, you get a level 4 visit. You just need to satisfy the level for 2 of the elements to reach a E&M level. So you don't need all 3. If you have all 3, great, bonus. All the extra work that you do to do the documentation doesn't give you a higher level. You just need to hit 2 of the 3 elements to reach a level. And notice, you may have noticed that I said problem, data, and risk. Problem, not diagnosis, okay? The number of diagnoses does not really matter. The number of diagnoses does not really matter. And if you really understand coding and billing, you know that if you have 2 chronic stable problems, that gives you a level 4 problem, right? That in that instance, the number of problems, not diagnoses, number of problems that you're addressing at that visit matters. Other than that, 2 acute chronics, 2 acute uncomplicateds, I can't really find any instance where I would have two of those to move me from a 2 to a 3. But commonly, we're dealing with 2 stable chronic problems. For instance, BPH with obstruction and erectile dysfunction. Chronic problems that you're dealing with. So 2 stable chronics 2 stable chronics. If you have 2 stable chronic problems such as BPH that is stable and ED that is stable, that gives you a level 4 problem. Not level 4 visit, level 4 problem, okay? Commonly, when we're dealing with BPH with obstruction or erectile dysfunction, you're commonly prescribing a medication. So you have a level 4 problem when you have ED and BPH that are stable, and they're stable because most likely you're treating the patient with probably tamsulosin or tadalafil or erectile dysfunction medication. Say you're giving the patient tamsulosin and sildenafil. 2 problems, stable chronic, it's already a level 4, okay? Data, you may have 0, big fat 0. And prescription drug management in the risk section is a level 4. So you have a level 4 problem, a level 4 risk, that's a 992-04214, whatever it may be. It's a level 4 visit. Even if you have 0 data, okay? Again, 2 out of the 3 elements are only 2 out of the 3. That's all you need, okay, in medical decision making. So stable chronic, 2 of them, and prescription drug management, that's already a level 4 visit. Now, common mistake that I hear and see is that urologists will simply double click on the medication and it brings it down into assessment and plan with no mention of the drug, how it's working for the patient, if the patient's suffering any side effects, if you're talk to the patient about other treatment options regarding, let's say, BPH or ED. No mention of that in the note. That is not prescription drug management. And if I were auditing your chart, you would get a big fat 0. Okay? That is not prescription drug management. Prescription drug management is not simply listing the medication in your EHR. It is you considering the risks of the prescription, looking at the patient, looking at drug interactions, looking at side effects, talking about treatment options, and then through shared decision-making, the patient wishes to continue on medication. Now, I know you all do that. I know you already do that in a fraction of a second in your mind after talking to the patient. But what is lacking is you writing down all that cerebration in your head, writing that down, and I hate to say this, documenting. Yes, documenting your thought process in your EHR. That is missing often, all right? That is often not there when I'm looking at the record. It just lists the medication. You need to truly perform prescription drug management. And if you want to learn more about prescription drug management, I'll link in the card up here if you're watching this on YouTube, a video that I did about prescription drug management. And I'll link it in the video description as well. So that is 2 stable chronics with prescription drug management. Let's just say this is a brand new BPH patient that you've never seen before who has horrible lower urinary tract symptoms for which after you discuss with the patient, share decision making, you decide to schedule the patient for, let's just say, cystoscopy. So problem, data, and risk. And the patient comes in with nothing. No data, no past records, no PSA, whatever. So this is a problem. It's a chronic problem. Typically, BPH is a chronic problem lasting several years. Chronic problem and not a treatment goal. So this is a chronic problem, not a treatment goal. This single problem is already at a level 4 problem. Okay? Not level 4 visit, level 4 problem. And you decide, after discussing with the patient, you're going to schedule the patient for a cystoscopy. So what is cystoscopy? What is the risk in cystoscopy? Cystoscopy, and if you look at the 97 guidelines, diagnostic endoscopy is a moderate risk issue. So when you discuss or schedule or recommend a cystoscopy, that's a level 4 moderate risk. So what is moderate risk? It's a level 4 risk. Okay? You have a level 4 problem and a level 4 risk. Just these 2 alone, you're already at a 99204. Super straightforward and simple. And if you decide to do a Uroflow PVR on the first visit, that's on top of the 99204. And there's no multiple procedure reduction when you do a Uroflow and PVR. Yeah. So if your payers are discounting one of those codes, you should not be taking a discount. In addition, if your payers are following the guidelines, no modifiers needed when you're using a Uroflow and PVR in conjunction with an E&M visit, a 99204. Anyway, these are some of the coding things that you should definitely be aware of. Another question that is commonly asked when I'm presenting to urology practices is in the issue, and the problem is in the risk section. For instance, you have a patient with prostate cancer, and you're talking about all the treatment options, including active surveillance, including extirpative surgery or radiation, or hormonal therapy for palliation. Say you discuss with the patient all these treatment options, right? But you do not make a recommendation regarding what you think the patient should do. All that discussion may not rise to a higher level visit unless you document that you recommend radiation, recommend prostatectomy, or whatever it may be. Once you make that recommendation, the level associated with that recommendation is then accounted for in the risk. That discussion alone, nothing, until an action is recommended and or taken by you, the urologist. So discussion, talk is cheap, unfortunately. It means nothing. But when you recommend a surgery or recommend a medication, then a risk can be attributed to that recommendation. For instance, a BPH patient with AUA symptom score of 26 and the bother score of 4, and the patient says, no, I don't want to do anything regarding my trabeculations and urinary retention and bothersome symptoms. But your recommendation is to undergo cystoscopy, possible urocuff, possible medical therapy, and you are recommending further workup and or treatment. When you make that recommendation, even though the patient is, nah, I don't want to do anything, your recommendation is what counts, okay? Again, you have to understand the rules of the game. And this, somebody responded after I posted this review of systems, someone responded and said that, oh no, I haven't taken a coding course ever. And my reply was that I 100% guarantee you're leaving money on the table and working harder than those of us who understand coding and billing. Just today alone, I saw 10 telemedicine visits, right? Super easy, sit here, do the visit, run on time. I'm able to show the patient the pathology, the imaging on his or her screen. Yes, you still can't do telemedicine in 2024, but the coding has changed, okay? The place of service is changing, the modifier is changing, so you need to be aware. And these rules, unfortunately, change every single year. For the urologist who said that he's never attended a coding course, I feel badly for you, okay? You are leaving a ton of money on the table, working harder than you need to, and which attributes to, I think, a lot of the burnout. A lot of urologists are working really hard, and they feel like they're spinning their wheels, running on a hamster wheel and not making any production, okay? You don't need to work like that. You don't have to work in frustration. You can do this happily and make the money that you deserve because you already do the work. It just takes a little bit of understanding on your part when it comes to this third-party payer game. And those of you who are aware of how this thing works, it truly is a game. Just like the IRS rules, it's a game, right? Thousands of pages of IRS regulations on taxes. And believe it or not, most of that documentation in IRS, in the tax code, is to tell you how to avoid taxes. Only a very small section is about increasing taxes and taxing you more. Most of it involve how you can decrease your taxes. So I digress. Those of us who understand the tax code or hire someone who understands the tax code and you do the behavior that benefits you regarding the tax code or coding and billing, you are going to benefit. Those are just the rules. And if you understand the rules, you apply the rules, you benefit. Okay? And if you don't have any coding knowledge, I would highly, highly recommend that you either get some training through one of the online places, or you can attend the Urology Advanced Coding and Reimbursement Seminar that's going to be held in New Orleans at the end of January in 2024. So you can be caught up on coding and billing and learn about the 2024 changes, which will have been implemented by the time you attend the course. And once you learn these rules, you can apply them throughout the rest of the year and not lose out on all the benefits. Okay? Every single year, the rules change. And it is incumbent on you, the urologists, the APPs, to learn these rules to your advantage. These rules are written for your advantage, okay? For you to utilize them to your advantage. It just saddens me. It just frustrates me when I see this type of documentation, all this extra work that is being done by the patient, by typically the medical assistants that are writing this down, and by the urologists who may need to review these records. And of course, nobody I know is simply clicking a button and applying a 13-point review of systems that is negative without asking the patient. I hope not, okay? I hope not, because that will put you in a lot of medical legal risk, okay? Not to mention compliance risk when it comes to billing and coding. And also, you don't need all that review systems since 2021, okay? You don't need all that. And when you document that negative review systems, should you do it, you better make sure the rest of the note is congruent with what you've documented, okay? Medical legally, it makes a big difference in what you write down in your chart, because that's a legal document. All right. As usual, if you have any questions, comments, leave them below. And if you think we need to do an E&M Q&A session, I'm happy to revisit that again. Last time we did that was around January 2021 with Mark Painter, and I can see if he has some time to maybe on a Saturday morning again, where we can do a half an hour, 45 minutes to talk about, do a quick fire Q&A regarding evaluation and management, coding and billing. As usual, any questions, comments, I welcome them. Thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.